Hello everyone, I'm here today at the beautiful Pronghorn Estate in Oregon with Bruce Brundage, eminent cardiologist, who has the distinction of being one of the people, along with I think Douglas Boyd, who developed the CAC or calcification scanning technology quite a long while back. So we're going to talk about that today and the exceptional nature of the test and its ability to predict and to see disease, cardiac disease, and go through some of the history and some of the controversy behind it. So I'm delighted to meet you, Bruce, and it's an honour.
My pleasure, Ivor.
So I think probably we'd start with the original kind of early days when you realised how powerful this technology could be.
Yeah, well, as you said, I was at University of California in San Francisco, was a young cardiologist, academic cardiologist, working as the director of the heart catheterization laboratory. And one day I was talking with one of the radiologists, and they introduced me to Doug Boyd, who was a physicist, not a physician, a PhD physicist. And he told me that he had this concept of building a heart scanner. He actually wanted it just for the heart. You know, scanners in those days were just a new technology, actually developed by Hounsfeld from England. And they were imaging many things and with exciting accuracy and insight into anatomy. But the problem was that those scanners took their pictures in such a sort of slow shutter speed that whatever they were imaging had to be perfectly still. So he came up with a concept of how you might be able to make CT scans that had a very fast shutter speed, which would basically freeze the motion of the heart. So he started building the first, and he called it electron beam tomography instead of CT, and it has to do with the technology of how you create the image. But the short of it is that I could see that if he could actually make this thing happen, it would become a powerful cardiac diagnostic tool. And I was in a very fertile environment for imaging at UCSF in those days. There were many areas of cardiac imaging, nuclear imaging, echocardiography that were all in their relatively early days, and it was exciting. And here was this other totally sort of off-the-wall concept of imaging. And so he created the first scanner, and he actually invited me down in the basement of the bowels of UCSF to where they had given him some space to build this electron beam device. And he invited me down the day he turned it on the first time. And it was sort of exciting to, at that point, I'm sure I didn't have a full recognition of the potential value of this imaging device, but it was still as exciting because I knew he had some great ideas. So long story short, he finally develops a company to manufacture these machines, because basically nobody else, including the NIH, was very interested in what he was doing, thought he was sort of off the wall and a little bit crazy, the mad scientist sort of scenario. And so he started making these scanners, and I was then moved to the University of Illinois in Chicago to become chief of cardiology there. And I sort of made one of my marriage gifts to go there was that I would the university would buy me one of these Doug Boyd scanners. So I think we got the third or the fourth one that he ever built at University of Illinois. At that time I was interested and other applications of this technology, particularly measuring blood flow within heart muscle. But in the process of imaging a lot of people who had had a heart attack, and I wanted to see if I could differentiate the flow of blood in scarred tissue versus normal tissue, we started seeing a lot of this, as my young people would say to me, "What is that, Dr. Brundage? What's that white stuff there?" And I said, "Well, that's coronary calcium. You know, when you get atherosclerosis in your coronary arteries, you get calcium. It's a part of the process." And so we began to look into it a little bit more, and I had known the work of David Blankenhorn from the late 60s, that he had shown just taking aortas at autopsy out of cadavers, that he noticed that there was a correlation between the amount of calcium in the aortas and how much atherosclerosis was in the aortas. And he actually published fairly extensively about it. Again, was relatively ignored because it was sort of an idea ahead of its time, because there wasn't much we could do about atherosclerosis actually it was the late 50s when he first paper, and then in the 60s. And so anyway, I got the idea, you know, this could be potentially valuable as a clinical tool if the amount of calcium in the coronary arteries that we could so easily see with this new technology correlated with the amount of atherosclerosis in the coronary arteries. So that was the very beginning, and I presented the first paper on it, I think in 1985, at the World Congress of Cardiology in Washington, D.C. And then I got Arthur Agustin interested in it, and an engineer who actually worked for Emitron, David King, who had been an engineer working with Hounsfield with the original CT scanners in England. They began to pursue even more quantification of, well, can you actually measure the total amount in a hard number and then correlate that with the calcium? So it's a long, many things went on after that, but the bottom line was, it turned out it was true, that the amount of calcium in your coronary arteries correlated linearly with the amount of atherosclerosis in your coronary arteries. Now, not every bit of atherosclerosis has calcium, but the relationship is linear and fixed. So the more calcium you have, the more atherosclerosis you have. And that was the beginning of the coronary artery scan, or coronary artery calcification scan.
Right. And that is actually quite huge, because you now can linearly assess the amount of atherosclerosis non-invasively in minutes, right, and get a distinct answer. Right.
And what we likewise didn't know at that point in time was, even if we did have a direct linear correlation, so that we could say, well, X amount of calcium equals X amount of atherosclerosis, what does that mean in terms of health, disease, and outcome? And we didn't know at that point in time. Again, in time, seems like it took forever, but in time, and many studies have shown that yes, indeed, the more coronary calcium you have, which means the more atherosclerosis you have, the more likely you are to have a atherosclerotic event, either a heart attack or a stroke.
And it does make absolute sense, but of course it had to be proved out, everything has to be proved, but it makes absolute sense that the higher burden of atherosclerosis is going to lead to more events in general, you would expect, and that was proven out, I think, again and again, really, with the studies.
Yes, no, it's been proven, as you say, again and again.
And the time frame then from the initial invention with Douglas Boyd through to the realization of what you just described, that yes, it does reflect the burden, and it does pretty much reflect endpoints and events. That time frame roughly from the 80s.
Well, actually, he developed the scanner technology was developed in the 70s, the late 70s, early 80s. The initial observation that we could easily quantify coronary calcium happened in the mid 80s to the late 80s. Arthur Agustin published his paper in 1990 on the coronary calcium score, and actually creating a quantitative score. And then many studies were done, but I would say the definitive study was the NIH-funded MESA trial, which was then published in the mid 2000, somewhere 2006, 2008. I don't remember exactly when the first paper came out, but so let's say it took 30 years, 25 to 30 years from the development of the technology to pretty substantial documentation that a calcium score was a good predictor of future coronary events.
Right. And even though the definitive proof arrived then, the ultimate proof, I guess long before that, understanding the technology, understanding the calcification process, it would have been highly likely that this would be an amazing tool to identify people at risk. But I think one of the tragedies is that, you know, from the 70s, 80s, where enough data would have emerged to know this could be really powerful, it really wasn't adopted until much, much later. So what are the key things behind the lack of adoption?
Well, that's the $64,000 question. I don't know the ultimate answer, or as you like to say, the root cause. But I'm sure it's multifactorial. There's an interesting observation made a number of years ago, as an article published in the New England Journal of Medicine, about how long it takes a medical discovery to reach what we would call clinical fruition, where it actually is incorporated, endorsed, and utilized in clinical medicine. And that turns out to be somewhere in the range of 20 to 25 years. Now, so part of the answer to your question is that's just the way it is in medicine. It takes a long time from a discovery to be fully incorporated into clinical medicine, even though it may have been proven relatively early to have potential value. And that may be in part because, you know, medicine's a pretty important. The health of people and their well-being is important, and you don't just jump willy-nilly from one new discovery to another and immediately incorporate it into everyday use. Medicine is conservative, and it says, you know, people's lives in our hands. We need to be darn well sure that before we incorporate this as an everyday tool, that it's extremely well studied and understood before it's incorporated. Now, obviously, there's a sort of a continuum there. You know, something that's really a significant breakthrough, you would hope that it gets adopted early as possible, because hopefully it will save people's lives and improve people's quality of life. But on the other hand, you just, as I said, you can't just jump willy-nilly from this new discovery just reported in the Wall Street Journal or the New York Times and have your doctor on Monday morning, after having it in the paper on Sunday, say, well, sure, I've got this and we'll be using this now on you. It just, as you can see, it doesn't make sense. But and then there are other things. In this country, in the United States, medicine is a business. and there's what we call fee for service, okay, which means that you get paid for what you do, and that results in people doing whatever they do as much as they can because they'll get paid more if they do more of it. And it means that there are multiple things that you can do, and so some people are invested in this doing, and some people are invested in that doing, and somebody's invested in another doing. And if you come along with an even newer doing, then you're competing with their doings, and you're having people who will try to prevent the newest kid on the block from getting established because that cuts into their piece of the pie. And there's one organizational group I met with in Chicago many years ago, trying to get them to certify CT scanning as having a, we call it in this country, CPT code, meaning that if you're going to bill for this procedure, you have to have a number. If you don't have a number, then most of the insurance companies aren't going to pay for it because they say, well, that doesn't have a CPT code. It's not validated. And so I sat before this group, and they looked me right square in the eye, and they said, Dr. Brundage, there's a pie. That pie is not going to get any bigger. And what you want to do is to cut a piece of the slice out of that pie, which means that there'll be less pie for us. Okay? So as hard as that sounds, that, I believe, it played a role in the slow adoption, acquisition of CT scanning for coronary artery disease, and specifically coronary calcium. There was another part of the story that I think is important too. Doug Boyd's company was a very small company. I mean, he had a great idea, absolutely genius, and but there were other big companies that were making CT scanners, but they weren't the fast CT scanner. They weren't the EBT scanner. Yeah. Companies like General Electric and Siemens and Philips. And those companies, I believe, did things to impede the adoption of this other type of technology because they were heavily invested in a different approach to CT scanning. Their approach to CT scanning was to mechanically revolve, rotate an X-ray tube around the patient. And that's mass and speed, and that is an issue. Whereas Doug's idea was you didn't rotate any mass to speak of, you rotated the electron beam around the patient.
Yes.
Okay?
That's high speed.
And for them to retool, it's sort of like if General Motors, someone came along with a kind of car that no longer used the internal combustion engine, and they had to retool their whole operation for a totally different kind of car or personal transportation, if you want to even think further outside the box, that they might just be out there lobbying against that new technology. And so I think the technology got lobbied in that regard as well. And then finally, I think that the competition with the other technology, other imaging technology, it was the newest kid on the block compared to nuclear medicine, compared to echocardiography. And then about the same time, slightly later, along came MR, or in those days we called it nuclear magnetic resonance. Then it changed to magnetic resonance imaging. And that was a competition. Of course, there were certain reasons and institutions and individuals who thought that that was the way to go. And so each is competing for their, for the attention, if you will, of the clinical community. And because the EBT company was very small, it was hard for them to get attention. And in the process of that, along came some young entrepreneurs who actually had a fair amount of vision that saw, well, if you have something that can accurately predict the potential for future coronary or heart attack events, wouldn't you want to get that out there for everybody? So they started to commercialize the scanning process. And there were companies formed. And that, of course, turned the medical community off completely, because they saw that as bastardization of what medicine should be about. It shouldn't be about trying to see how much money you can make, selling a scan. And so that definitely was a detriment to its development. So again, it was multifactorial, many, many things, and there are probably things that I don't even know about, or things that I thought were unimportant that were more important, but that's my view of it.
Very good. And I think as well, Bruce, or Doug or yourself mentioned in the movie that a study was done possibly in the Mayo Clinic where they realized that using coronary calcification, you could maybe halve the number of unnecessary angiograms. And that would actually, but the problem is with that is commercially there was so much revenue from doing the invasive angiograms that this new tool would just actually drop revenue.
Well, that's part of what I just was talking about. I mean, whatever ox you had to gore, you would, so it impacted many people. Yeah. But yes, I wrote about that many, many years ago, that maybe what we should be doing is that everybody, before they go have a, quote, diagnostic coronary angiogram, should have a CT scan, which would take just a couple of minutes, very little radiation, painless, non-invasive. And if they had a calcium score of 0, unless they had compelling symptoms, forget about doing a coronary angiogram. And even up until 5 years ago, if you go to the American College of Cardiology registry for coronary angiograms, and they keep a big registry of many hospitals, not all, but many hospitals, feeding their angiographic results into this data pool. They showed that up to 30% plus of angiograms, 5 years ago, 30% of angiograms performed in this country were totally negative, totally negative. Now, a CT scan would virtually eliminate all those angiograms. And yeah, I'm sure hospital administrators like the revenue stream from a cardiac cath lab, and if you tell them they're just going to reduce it by 30%, that might not set with them too well. But those are the facts of life. I mean, that's reality. We don't live in a perfect world, and I'm not trying to castigate or damn those people. That's just the way things are. It's how it runs. And but all those forces like that certainly played I think a part in the slow adaptation, or a slow adopting rather, of coronary calcium scanning. But here we are, 2016, some over 30 years later, and there hasn't been really one piece of data presented anywhere that has refuted what we originally said. This is a marker of atherosclerosis. The more atherosclerosis you have, the higher your risk of having a cardiovascular event.
And the numbers are quite stunning. When I was introduced to it by David, I know you know David Bobbitt, within a few minutes of researching it, I began to hit on these incredible numbers of predictive power. And then I discovered the paper in the file which showed the calcification, if increasing at a high rate yearly on multiple measurements, was even massively more predictive. It was just extraordinary. I think in a study increasing at greater than 15% per year, 50% of those people had a heart event within 3.5 years, versus people increasing very slowly, as in less disease growing, had only 3% after 6 years. And as an engineer, I'm looking and I'm going, oh my God, not only is this test incredibly accurate compared to other ones, but if you measure it sequentially and look at the vector of where it's going, it's beyond incredible. And so I know you don't want to adopt a new medicine too quickly, but this is, just a scan. It's not like bringing in a new medicine that may backfire. So it's kind of extraordinary, the lost opportunity of 30 years.
Yeah, it is. In the documentary that was made, Widowmaker, I was asked, if it had been adopted, in the mid-'80s or early '90s, when we had pretty solid information that it was of value, would we have saved, how many lives we would have saved? And I said, a lot.
A huge amount.
Yeah.
Because the medications and the treatments for heart disease, if you know you have it, we're getting pretty effective.
Yeah, that was the other part of the equation that was important. I mean, if you have a test that diagnoses something, but there's nothing you can do about it, even though you diagnose it, then it doesn't make a whole lot of sense. But that was the era in which statins and other cholesterol-lowering medications, a recognition that smoking was associated with coronary atherosclerosis, the risk of high blood pressure. We had ways we could modify those kinds of things, and so it was important that we could identify those at the highest risk, because we could potentially prevent the adverse outcome.
Yeah. And again, also the causes or treatment to be multifactorial, there's medications, lifestyle, but at least a person who suddenly realized, my God, I have an enormous amount of disease, who may the day before have thought, I'm okay.
Right.
They'd have the opportunity, and that opportunity cost has been enormous, or the loss.
Right.
And in terms of, the cost also is very low.
Yeah, relatively. I mean, a coronary angiogram is in terms of thousands of dollars. A coronary calcium scan, I think it's fair to say that a couple of $100 is the maximum that it should cost, without losing money, without giving it away. So, yeah, it's not high cost. There is radiation involved, but the amount of radiation is trivial. And in the whole, realm and perspective of things, it's really not, in my view, relevant to say don't have the scan because there's radiation involved, because of the risks. The benefits clearly outweigh those types of risks. It's been a long journey. It has taught me many things about life in general, about mankind in general, but still it's been a worthy journey. I mean, one that's been rewarding, and even though it's taken a long time to have the value of the test recognized, it is more and more recognized today, and I hope someday, soon, we come up with a better test. It's something that'll be even better than this. But right now, I can't think of anything that could identify the risk of having a coronary or a cardiovascular event, stroke as well, better than coronary calcium scanning.
And when you're actually looking directly and relatively easily at the disease process itself, it's understandable that it's hard to find a better measure, because what's better than seeing the extent and presence of the actual disease process, which is what it does. There's a lot of arguments made against how powerful it is, and we spoke of one earlier. It doesn't catch soft plaque that is not yet calcified, and I just thought you were very emphatic and clear on how that is a non-valid argument.
Yeah, I mean, again, if you don't understand that, you're missing the whole point. That the calcium, it's sort of like an iceberg. And if you float an iceberg in the ocean water, the water has a specific gravity, and related to the ice, so much ice is going to stick out of the water, so much ice is going to be below the water. But however big that iceberg is, the amount sticking out is directly proportional to the amount that's below the surface. So for someone to say, well, but it's not the calcified plaque that causes the heart attack, that's not the point. The point is, the more calcium you have, the more soft plaque you have. The more soft plaque you have, the greater your risk of having a heart attack. So I used to tell my patients, if you have one soft plaque in all your coronary arteries, your chance of having a heart attack is infinitesimally small. But if you have 10,000 soft plaques in your coronary arteries, your chance of having a heart attack is pretty damn high. And if that's the case, then you'll have a lot of calcium in your coronary arteries, which goes right along with all the soft plaque that's there.
Exactly, and that was really put very well, I'll have to say. I've recently, as I've been kind of promulgating this information about calcium scanning, one person, a good guy, great guy, doctor, sent back and showed for diabetics, even a 0 score, at 15 years, where an average person with a 0 score kind of has a 15-year warranty, it's that predictive, but diabetics can have 9% events at 15 years. But if you look at the actual graph, for 0 to 5 years following their 0, they have no events. And then 5 to 10 years and 10 to 15, they have events. So all that says to me is diabetics, who are at huge risk of heart disease progression, just need to get it more regularly to know when they're going into this danger zone.
When their plaque burden gets to the threshold at which clinical events start to take place. But as long as your calcium score is 0, the amount of soft plaque you have is so small that we have proven that your chance of having a coronary or cardiovascular event is infinitesimally small.
Exactly. So even for diabetics, if you check in and ensure you're still 0, you've still got a low risk. But the key is you need to check. Because how are you going to know at year 7, 8, 9 when your score goes up to 100, 200,
and the same thing is true as you grow older.
Yeah.
You may have calcium score of 0 when you're 40. That doesn't mean you're going to be plaque-free for the rest of your life. One of the greatest risks for atherosclerosis is age. Yeah. The older you are, the more likely you are to have atherosclerosis. But we don't know if you do or you don't until we scan you. We scan you, then we say 0 score, you have so little atherosclerosis in your coronary arteries that your chance of having a coronary event, certainly in 5 years, is trivial. And in the paper you mentioned, which is, a very large study, showed that just populations in general, a score of 0 is your chance of having an event in 15 years is, again, trivial. But subgroups, such as diabetics who have unusually aggressive atherosclerosis, theirs may progress faster than the general population would in 15 years. So, we always tell the patient a score of 0 doesn't allow you to go out and eat Big Macs and just forget your diet and put on a weight and smoke and do all those things. It's not a lifetime guarantee. It just is at this point in time in your continuum of life, you're still in the low risk category. But that could change with time. And the longer you live, the more likely it is that would change.
Yeah. And the imperative for diabetics is not to not trust the calcium scan, but it's just to get it regularly enough to know if they're really going into danger zone. So very ironic. Yeah, so hopefully it's in the ESC, the European Society of Cardiology guidelines since 2013. It's given, I think, a 2A rating, a pretty high rating for evidence, for predictive. But the deployment of it, I think, is still really low. It's just captured in the guidelines.
Same in the United States.
It's the same thing.
Same thing. And
The ACC/AAH guidelines for intermediate risk, give it again about a 2B or 2A score. I think it's 2B, which just means that it's pretty doggone well verified. And still, it's, as I was telling you earlier at dinner tonight, I just had a medical student in my clinic in the last month from one of our only medical school in Oregon, and he was totally unaware. He's just about to he graduates this month from medical school, and he was totally unaware of the coronary calcium scan.
Unaware of the fastest, least invasive, most powerful predictor of future health.
yeah,
Unaware, not so aware, kind of unaware.
totally unaware.
And that just brings to mind another thing, that recently papers have been coming out, I think some from MESA actually, and from those databases, and they're beginning to kind of say calcification doesn't just predict coronary vascular issues, because they've looked at the hazard ratios for cancers and arthritis.
Interesting.
And they're
Interesting
seeing
study.
like 3 and 4 HRs
Yeah.
for all these diseases. Now, to be honest, to me, that kind of makes sense, because problems, and as we said earlier, cardiovascular disease is multifactorial. There are many ways to drive problems in your body. Smoking, bad diet, lack of exercise, lots of factors. But generally, all those factors will tend towards an inflammatory state that will drive other diseases. So in a sense, the calcification predicting other diseases is not so much a surprise or an enigma. It's kind of like, well, okay, it's not too surprising. But if so, then the calcification is of even more value.
Right.
So it's
And
huge.
and as you say,
It may indicate that that risk factors that lead to coronary atherosclerosis in general, may lead to other diseases as well, whether that's through the pro-inflammatory effect or other effects. I don't think we know yet, but it is a very provocative, and that's a very, from a scientific standpoint, a very solid study, because it was a prospective, randomized screening of asymptomatic population, which they now have followed more than 10 years, and it's probably coming up on 15 years, and they're beginning to mine this data set for other things beyond the primary question, whether or not coronary calcium predicted future events, which it showed outstanding power. I mean, we're talking power tenfold over other traditional risk factors.
It's extraordinary. And the beauty of that trial as well was, unlike kind of nutritional questionnaire trials where there could be bias or recollection problems, I mean, that is simply a scanning.
right?
So there's no inherent bias. Whatever comes out is reality. And like I say, so powerful.
The recruitment, and it was which is important for this country, which is become very multicultural, multi-ethnic country. It showed the power across multiple ethnic groups, not just white male Caucasians, but African Americans, American Asians, etc. It shows the story is true for all human beings. The more atherosclerosis you have in your vessels, the more calcium you have in your vessels, which is easily detected by a technology called CT.
And enabled enables you to essentially, as the Widowmaker movie says, effectively save your own life. Should you choose to do so, I'm sure there are some people who will get it and say, okay, and maybe not do a whole lot. There has to be a huge proportion of people who will realize, like when they get a PET scan and there's a tumor, those people sit up and they do things a lot differently when they find out they have a tumor. And in a sense, this is analogous. You get shown you are full of disease. You're seriously diseased. It's not a question anymore, not a risk factor.
Right.
So it's, yeah, the lost opportunity is painful in a way. I just think when we're talking about all cause as well, the metabolic syndrome and insulin resistance syndrome is a lot more focus on. Funny, that's similar also, that although originally it was being looked at as giving a higher degree of atherosclerosis, cardiovascular disease, if you had metabolic syndrome, now it's kind of branching out that if you've got it, a lot more diseases are increased in risk.
Right.
So, and I suppose it just speaks to the, if the system is out of whack, a lot of negative processes
Right.
tend to occur.
A lot of risk factors are probably multifactorial.
In themselves.
Yeah. I mean, myself as a cardiologist, we sort of have the blinders on and we're just looking at the heart and blood vessels. But if you took the broader view, you may, we begin to recognize that there are other organ systems that are affected as well.
Are there any last thoughts or kind of fundamental feelings? I'm thinking perhaps on, well, all the people who are lost is one thing, though we did touch on that. That's probably the hardest thing, knowing you had that technology. Fledgling, but you really knew very early on how powerful it would be. And then all the lost opportunity. That must be tough, I think, for Douglas Boyd as well, probably.
Yeah, it is, but I'm sure there are many other instances in medicine where discoveries were made that weren't adopted rapidly enough, or the resources were not available to make them adoptable. But I always see the glass as half full rather than half empty, and we've made a lot of progress in our understanding of atherosclerosis, as we discussed earlier this evening. It's multifactorial. Whatever we think we know today in 2016, I'm sure in 2076, people will look back and think that we were relatively naive, and there's so much more to learn, and that's the exciting part. I know what I would tell young people. Young people ask me about, should I go into medicine? I have a nephew, actually a grandnephew, and he's going to medical school, and he called me and said, with all that's going on with healthcare in the United States and the Obamacare and Medicare, and I said, that's not important. What's important about medicine is you get to help people, and if you want to help people, then it's a great profession. I don't care what the economics of the profession are, and it's the same thing about the science of medicine. It's what always intrigued me and actually got me interested in medicine was there were so many scientific answers to be obtained and searched for, and gosh, we just, every day something new was being discovered and another breakthrough, and I'm sure it'll keep on going like that, and I'm not sure that we'll ever be 100% cured of atherosclerosis, but we've made tremendous inroads in my clinical career as a profession, and I'm sure that will continue in the future. The glass is still half full.
Well, as a final word then, what would you say to those people out there, middle-aged men and women, who have a couple of risk factors but aren't really sure whether they have a disease or not, and whether to do something really aggressive?
I'd say what's on my license plate: get a scan.
Excellent, and I have. Many people I know more and more are doing that, and many of them are finding out things that they're surprised at, and they are really taking action and taking advantage of the knowledge.
That's the
there.
important thing. Knowledge is power.
Yes.
And if you have the knowledge, you can take control of your life in that regard. And you know, if you choose not to, that's fine. That's your choice. But to have the knowledge and the power, then you can make. There are changes that you can make if you choose to, that will definitely improve your health
And your future.
And your future.
Well, listen, thanks very much, Bruce. Delighted
My
to meet you
pleasure.
tonight. Thank you. Thanks, everyone.